Yeah, thank you, Eric and Allie. I appreciate the opportunity to speak. There are two things that I've heard over and over again since I got off the airplane here, and that is that the Endovac is great and Steve Leeds taught me how to do it, and I'm using a video from Eric Pauli. Well, I don't have either in this, so I'm not going to talk about sleeve leaks, and I don't actually have a video from Eric Pauli. I did not do that on purpose. Let's see. I do have some, I don't know how to go back here.
Go back one slide, please.
Yeah, I have disclosures. I'll just point out that though I will be talking about equipment from some of these companies, I really don't think anything is relevant to the content. So we've all heard, sleeve gastrectomy is here to stay. It's becoming more and more common. And with that, we're going to see an increased need to take care of sleeve leaks. So they're not common, when 60% of our bariatric patients are undergoing sleeve, we are going to see some sleeve leaks. So it really behooves all of us to learn how to treat these patients. And the factors to consider, which have been brought up a few times earlier, but when we're going to approach a patient like this that Eric brought up earlier, a 35-year-old who just had a gastric sleeve, we need to know where's the location. Is it somewhere that it will be easy to put a scope with a big endoscopic suturing device on it, for example? What's the size of the perforation? A smaller perforation might be a little bit more amenable to a clip, for example. What's the chronicity of the leak? A leak that's been around for months is less likely to be closed endoscopically, in my opinion. What are your available resources? Do you have a dual lumen scope? Can you even think about an over the scope clip? Do you have those at your institution? Is there an abscess? Do you have source control, as Steve mentioned? How are you treating that abscess? And then what's the stability of the patient? As we've heard before, I agree 100% with the other folks. You have an unstable patient with peritonitis, probably needs surgery. And then is there a stricture distally? As we all know, if we try to endoscopically close a perforation and do nothing to treat a distal stricture, you have probably near 100% failure rate. I don't think any of us would disagree. So I think it's funny that people have shown the different protocols up here, because what I looked for is a standardized protocol on how to treat these patients, and it turns out that there's not a standardized protocol. So here's one from Mark Ward and Steve Leeds' group that is actually really good. It talks about the stability of the patient. I actually think this is the best one that I found. Stability of the patient, chronicity, but what it doesn't tell you is what to do. If you look in that middle column there, it gives you all these different options, but which one should we use? We don't know what to use. Here's another one that doesn't even talk about stability of the patient. It doesn't talk about chronicity of the perforation or the fistula. And it actually doesn't even talk about evac, which, as we all have heard since we got off the airplane, is the best thing since sliced bread. And then here's another one that, again, this one actually does talk about hemodynamic status, but does not talk about chronicity. And again, doesn't include the evac. So I think the bottom line is this. Most of us in here, or maybe all of us except for Allie, are surgeons. And so we've been dealing with holes in the GI tract for centuries. We know how to deal with holes in the GI tract. We deal with ulcers, we deal with anastomotic leaks. And I would actually tell you, we should not treat, these holes any differently. We can close some of these holes acutely. If somebody comes in with a perforated gastric ulcer, we actually close those. So I think to say we can't close it is wrong. But I think we have to think about what's the comorbid status of the patient? What's the chronicity, the size of the perforation? How likely is it to heal? Do we have anything that would keep the fistula, open? Those are the things that we have to think about. And if we think about it in that way, I think we can handle these pretty well. So I'm going to talk a little bit about my literature search on endoscopically closing these perforations and a little bit of my own personal experience as well. So I think through the scope clips are the first thing I'll talk about. I actually think these are the least effective. These are technically easy to place, and they do come in increasingly wider forms, which has been really nice to use. I think these are absolutely fantastic to close mucosal defects. I use these all the time. As a matter of fact, this is probably the most common closure method that I use, but not for a sleeve leak. I'll use this during a poem or a pop. Where I'm just only needing to close mucosa, because that's about all that these clips get is mucosa. They don't get muscular or the muscularis or the submucosa. There are actually 2 case reports of successful closure, only 2. These are very vague case reports. They don't talk about did the patient come in with an abscess and how they dealt with it. They have no long-term data. They just say, hey, it worked. Patient, left the hospital, but, how long did the patient, actually stay? I have experience where I've closed a fistula and been very happy, and then 2 weeks later the patient came back and it was leaking again. So, I would just caution a little bit about these. I would say that I would use this to close a sleeve leak if I were in a hospital where all I had were clips. and I would have very low expectations, and I would tell the patient that I have very low expectations. And I kind of like this guy. I don't know if it's going to play, but this is a guy. This is a guy that should have very low expectations that carpet is going to get clean.
It's just a guy working on Steve's basement.
Yeah, exactly. That's it. He's working hard, though, and that's, I think, how it would be with these through-the-scope clips. And, yeah, he did do a good job, though. Steve's basement looked incredible afterwards. Okay, so anyway, next is endoscopic suturing. So I actually like endoscopic suturing. I think it works well. It's a very secure closure with deep bites. The curved needle actually goes full thickness in most cases. It is technically challenging. You do need to learn how to use this device. And there's actually, again, one series out there with 5 patients that specifically addressed using the overstitch to close a sleeve leak. And they actually had pretty good success. The one thing that they noted is that all 4 of the patients out of the 5 that did succeed were all early, within 30 days, and they were, able to close those patients. But again, a little bit vague on long-term follow-up. Didn't really talk about how they addressed, infection outside of the sleeve leak. But again, I think this is not unreasonable. I've actually used this before with success. I oftentimes will close the defect and stent it. I kind of think of it as a reverse gram patch where you kind of close but reinforce. And so I do think that this is an option that would work. But again, I would probably agree with these authors. It would have to be an early leak and a leak that, that is in a location where I can get the suturing device confidently there. And I probably would stent at the same time, and I would need to drain whatever fluid is out there. The last method I'll talk about is over-the-scope clips. This is actually by far the most reported method to endoscopically close a sleeve leak. As you can see here, I'm not going to go into how you do it and how you use it, but if you don't know how to use an over-the-scope clip, you should, because I think these work well in addition to learning how to suture. They come in variety of different jaw shapes. There's, small blunt teeth, which are really meant more for hemorrhage control. But then there's some sharper and even longer teeth that are really good for fibrotic tissue and perforations. On the bottom picture there, you see a twin grasper. There's also an anchor that you actually can put the anchor through the perforation, open it, pull it back in so that you can really get a good bite of the muscularis. And if you can get that, then you get more of the mucosa. It's a little bit more secure. So in terms of the data, actually a lot of studies out there. I think really the one that I just focused on here was the systematic review that included 10 good studies with 195 patients, and they actually had a pretty good success rate, about 86% success at closing a sleeve leak. The predictors for success were, as we can all imagine, early leaks that are small. So these clips actually can close up to 27 millimeters, but the smaller the better. The smaller the perforation, the more likely you're going to get that tissue in there and be able to close it. Again, this is something that I have used also in addition to a stent, and it's worked pretty well. So in conclusion, some leaks can be endoscopically closed. Obviously, the earlier and smaller the leak, the more likely you are to be successful. And I think it is worth a try if you have a stable patient with a controlled fistula. Over-the-scope clips are by far the most studied means of all the 3 that I mentioned. But there's really poor long-term data. And I agree with Steve. I think pooling our results and trying to really figure out a good standardized protocol is really needed. So thank you very much. Appreciate the opportunity.